That light comes on, then you're
Then hit it.
come on and you're good. And then it's on. It'll be red and then you're cool.
Good morning. It's 9 o'clock, so we're going to go ahead and get started. Hopefully, we'll be able to take a break somewhere along the way and then finish at 12. We've got folks from out of town that need to get back to home and patients and work. My name is Lee Hawkins. I chair the Health Committee in the House of Representatives. We're going to go down and let each one of our committee introduce themselves. You can do it from your seat, or I know one wants to come up. It's your choice, okay? But before we do that, I would like to introduce Scott Steiner. He is CEO of Phoebe Hospital, and he wants to say a few words. And want to thank Phoebe for having us here and providing this space for us. Thank you.
Good morning, everyone. As Chairman Hawkins mentioned, I'm Scott Steiner. It's my privilege to be the President and CEO for Phoebe Putney Health System. Thanks to the committee for being here today, and for those of you who joined us last night. It was great to meet some new friends. And Dr. Kiker, we had a really nice discussion about what it means to serve rural communities, and so thank you for that. So just a little bit about the building that you're in. We call this a living and learning community here. This is a partnership we have with Albany Technical College. We, like just about every other healthcare organization, have a shortage of workers, and nursing is really at the top of that list, but certainly physicians and lab techs and radiology techs, you name it. Accountants, boy, if you have some accountants around, we could sure use some of those. But we went to Albany Technical College. We went to Georgia Southwestern, Albany State University, ABAC, Georgia Southern, and said, how can we help? How can we help you recruit and teach more students and into a healthcare career? This is one of those visions, and we have partnerships with all of those university and colleges that I mentioned, and they all look a little bit different. This is probably our largest, but we took an existing high school that was 100 years old, Albany High School, and met with the community and said what was most important to them, as the facility was not renovatable, and they said that what their biggest memory was the front entrance, and so we preserved that entire front entrance. If maybe you didn't see it on your Depending on what navigation system you're using this morning, you maybe drove around it a few times, but we preserved that old front entrance, but we built this 80,000 square foot, 120,000 square foot building. And this first floor is dedicated to Albany Technical College and their teaching. In a normal semester, they would recruit about 30 to 40 new nursing students. And we opened this building last August, and their first class was 152. And so we are really excited about that partnership, and that's why we see this as a true partnership, not only here, but those that we have with our other schools and universities. We've got other academic institutions that we also call partners. Dr. Patton is here from the Medical College of Georgia, who has been, Dr. Patton, how long y'all been here? Yeah, so for a number of years, they have third and fourth year medical students that come here, a 2-year regional campus. The University of Georgia has their pharmacy program here, and both those programs have students, doctors and pharmacists, soon-to-be pharmacists, living on our campus here. Either some are in this building, some are in a building we call Flagstaff, just a block away. And we also have Dr. Rivers. Dr. Brian Rivers is here from Morehouse University. Thank you for being here, Dr. Rivers. And Morehouse is another partner that we've had, especially as we talk about cancer. And for a number of years, Dr. Rivers has come down and talked about access, especially for men and prostate cancer and the prevalence of that in our community that is unrecognized, undiagnosed, and a lot of times untreated for, as you all know, for a number of different reasons. So we rely upon these partnerships. Cynthia Merchant is here from Horizons Cancer Coalition, who has been doing this work for decades, but doing the same thing, looking, screening, access, and prevention. And that's what's important. And of course, like any hospital, we have an incredible team of caregivers, hematologists, oncologists, surgical oncologists, radiation, you name it. We have a full service of cancer programs, and a lot of our leadership team is here today. They do this incredible work. So we welcome you. We welcome you to Southwest Georgia. We welcome you to Albany, and we're looking forward to hearing it. Thank you, Chairman Hawkins, for the opportunity to be here.
Thank you. Thank you, Scott. Let's go ahead and introduce the panel, starting on my left. Dr. Cortez.
Good morning, everybody. My name is Jorge Cortez. I'm the director of the Georgia Cancer Center at Augusta University, at the part of the Medical College of Georgia, and my pleasure and honor to be part of this committee. Thank you.
My name is Chris Kiker. Work in Stevens County. I'm an outpatient family doctor in Northeast Georgia. Have the privilege of serving patients there.
Good morning. I'm State Representative Gerald Green, and welcome to the district. And we're delighted to have the committee in Albany today and Dougherty County, and we look forward to working with each and every one. And I really appreciate being on this committee and representing Southwest Georgia.
Sitting to my right is Morgan Hall, our budget and research analyst, and my right arm, and I thank her for being here. She doesn't have a mic, so.
Well, good morning, Chairman Hawkins and members of the committee. Thank you for allowing me to serve on the committee, but this will probably be all I say today, but I felt like sharing my story with everyone would kind of give you a little background about why I'm passionate about this. I am honored to serve on this committee, and I'm humbled at serving not as a legislator or a physician, but as a living, breathing example of what access to community cancer care in rural Georgia can mean. My name is Spence Mullis. I'm the chairman and CEO of Morris Bank. We're a $1.5 billion community bank based in Dublin. We have 9 offices in Middle and Southeast Georgia. Nearly 5 years ago, I was diagnosed with a rare and aggressive stage 4 abdominal cancer. Only 300 to 500 individuals in the United States are diagnosed with this particular cancer each year. The odds of surviving this cancer are devastatingly low, and yet by the grace of God and the care I received, I'm here today. But my story isn't just about beating the odds. It's about the good Lord, the people, and the care systems that made it possible. I began my journey in my hometown of Dublin, Georgia, with a primary care physician who paid attention and ordered some advanced testing when my blood work didn't look quite right and I was experiencing pain in my chest area. The CT scans I had revealed something suspicious that looked like it might be a type of cancer, but the tests were inconclusive. So my primary care physician referred me to a local surgeon. The surgeon performed an exploratory surgery on me and removed several tissue samples for testing. Although the surgeon was hopeful, as he said it didn't look like cancer to the naked eye, the biopsy unfortunately confirmed my worst fears. It was indeed this rare form of cancer. My surgeon called me to give me the terrible news one morning, but by mid-afternoon that same day, I got in to see Dr. Harsha Vyas, a primary care community oncologist who owns one of the last independent oncology practices in the state of Georgia. Dr. Vyas had never actually seen my particular type cancer before, but instead of sending me elsewhere or giving up, he partnered with an Emory surgical oncologist at Winship in Atlanta, Dr. Maria Russell. Together, they designed an aggressive treatment plan. And if the plan worked, the tumor board at Emory might approve Dr. Russell to perform what is known as a HIPEC surgery on me. First things first, I had a chest port put in, and I began intensive chemotherapy at Dr. Vyas's office in Dublin with 2 strong chemo drugs, cisplatin and pentrexid. On the days I wasn't receiving chemo, I still had to go to Dr. Vyas's chemo suite where fluids and nutrients were administered through my port to keep me hydrated and to help protect my kidneys because the 2 chemo drugs are especially hard on a patient's kidneys. Living just 10 minutes from his practice was an absolute blessing. But I met many fellow patients in his chemo suite who traveled 50, 60, 70 miles each way every day for their care, which is a testament to Dr. Vyas's reach and commitment. After completing my first rounds of chemo, Dr. Russell took my case to the tumor board at Emory and asked if they thought it was worth trying to save me by allowing her to go in and cut the tumors out throughout my abdominal cavity and then administer hot chemo directly into my body cavity in hopes of neutralizing the cancer. Again, by the grace of God and the power of answered prayers, the Emory Tumor Board agreed to allow Dr. Russell to try the HIPEC procedure on me. They made a long incision just below my breastbone down to my pelvis to open me up. In total, Dr. Russell spent over 8 hours cutting and removing all the cancerous material she could see with the naked eye. And then they glued me back together. The team then inserted tubes into my abdomen and ran hot chemo throughout my body cavity. The doctors literally took turns placing their hands on my abdomen, manually shaking me for 2 straight hours, trying to ensure that the hot chemo reached every crevice of my abdominal cavity. Folks in the oncology world have a weird sense of humor, as this HIPEC procedure is known affectionately as the shake and bake. I spent a week in the hospital at Emory recovering from my shake and bake, and then I headed back to Dublin. To describe the pain of being split open, having warm chemo sear every nook and cranny in your abdomen, to call that excruciating would be a profound understatement. But I was blessed. I was blessed to have the opportunity to go through it, as it helped keep me alive. Once I regained my footing, now being 80 pounds lighter than I was when I started my original chemo treatments, I returned to Dr. Vyas's office in Dublin for additional rounds of chemotherapy along with daily infusions. Again, imagine if I had to travel 2 or 3 days every day, 2 or 3 hours every day to do that. I don't think I would have made it. I don't think I could have made it. But because of that access and because of that commitment, I'm now here 5 years later, cancer-free. If my scans in July, just this next month, are clear, I'll get the opportunity to move to annual checkups a milestone that I once thought was impossible. But my story isn't just about me. It's about rural Georgians who deserve the same chance I had. Dr. Vias didn't have a university name on his building. He didn't have a huge hospital system behind him. But what he did have was autonomy, experience, courage, and most importantly, proximity. He was there, and it saved my life. As you can imagine, the drugs I had to take during my battle were expensive. When I was diagnosed, I was actually chairman of the Georgia Bankers Association. I was fortunate to have good insurance through the Georgia Bankers Insurance Trust, which covered most of my expensive cancer drugs and care after meeting my deductibles. But I also saw the system's flaws up close. My wife, who is severely anemic, has had to spend time in Dr. Vias's chemo suite over the years having iron infusions. I'll never forget the first time that she and I were both hooked up side by side in the chemo suite, both receiving treatments at the same time. One day when I was back at work, she called me in a panic as her pre-authorized iron treatment, the one that Dr. Vias knew worked best and stayed in her system the longest, had been denied by our insurance company. They were pushing Dr. Vias's office to use a less effective alternative that we knew did not work for my wife. I left the bank and I went straight to Dr. Vias's office, and I told them to tell the person on the other end of the phone to just forget it, that I would cut a check for several $1,000s to ensure that she got the right treatment that day, the one that actually made her feel better. Miraculously, after heated discussions, the original treatment was approved. But not every patient has the means or the influence to navigate these barriers. Pre-authorization denials have become commonplace for private physicians who have the experience and the knowledge to know what works best for their patients. This committee has the opportunity to address such obstacles, ensuring that patients across Georgia receive the treatments that their doctors deem best. The stories I've shared with you are why this committee matters. It's why the resolution to create this committee matters. This committee has the opportunity to shape policies that save lives like mine, to strengthen community-based cancer care, and to support providers in rural areas where the needs are only growing. It's about empowering community providers like Dr. Vias, who know their patients, who run into them at the grocery store or at the ball fields, who fight for them, and who don't give up when things get hard. It's about empowering these providers with resources, support, and the freedom to act quickly and decisively to save lives. Rural Georgians aren't statistics. We're not just zip codes. We're fathers, mothers, teachers, firefighters, and yes, even community bankers. We need care where we live, from providers who know us and have the knowledge and the dedication their patients and communities so desperately need. So as you deliberate, I ask you to remember this: cancer doesn't wait, and neither should access to the care for cancer. The survival of a rural Georgian shouldn't hinge on their zip code or how far they live from an academic medical center. It should depend on the quality and the proximity of the care that they can reach, care like I received from Dr. Vias just down the road. Let's not allow outdated policies or bureaucratic red tape to stand in the way of that care. Let's champion a system that sees patients as people and not paperwork. You have a rare opportunity to make decisions that don't just change lives, they save them. And I know this firsthand. So again, I thank everyone for their time. I thank all the members of the committee for your service in ensuring that Georgians in every corner of this great state get the fighting chance they deserve. Again, thank you.
Mr. Mullis, thank you so much for sharing your inspiring experience that serves as a guide for all of us as we deliberate in this committee. I'm Dr. Suresh Ramalingam. I'm a medical oncologist. I specialize in the treatment of lung cancer. And I also serve as the executive director of Emory's Winship Cancer Institute, which is our state's only NCI-designated comprehensive cancer center. I've been in Georgia for 18 years. Our mission at Winship is to discover cures for cancer and inspire hope, and reduce the burden of cancer across the state of Georgia. Thank you for allowing me to serve on this committee.
Inspire hope. Thank you, Doc. That was wonderful. I'm Karen Mathiak. I represent District 82, which is Spalding and Fayette counties, kind of middle Georgia. I'm blessed to be under Dr. Lee Hawkins' Healthcare Committee, and I'm glad to be here today. And wow, what a wealth of knowledge we will have at the end of this day. Thank you.
Hello, I'm Dr. Doug Graham. I'm a pediatric cancer doctor at Children's Healthcare of Atlantis. I'm the physician leader, the chief of the Aflac Cancer and Blood Disorder Center. Our center also has a partnership with Emory University and the Winship Cancer Institute, so we represent the pediatric arm of the Winship Cancer Institute. And thank you for allowing me to be part of the committee today as well.
Thank you to the panel. And our first presenter this morning is Megan Andrews with DPH Cancer Services. Megan?
Hi, Chairman, members of the committee. I'm Megan Andrews. I'm the Assistant Commissioner for Policy at the Georgia Department of Public Health. Thank you for having me today. I am going to talk about two programs that fall under DPH's purview that provide cancer services to patients in Georgia. The first is the Breast and Cervical Cancer Program. Since my lovely friend from House Budget is here, this is the budget for this program and the fund sources. So $4.4 million comes from federal funds via a CDC grant. 1.8 comes from state funds, and then another portion comes from our tobacco settlement funds. What this program does is it provides breast and cervical cancer screenings at health departments around the state of Georgia, as well as diagnostic costs. So, as many of you know, there is at least one physical health department location in every county in the state of Georgia, and these services are available in at least one county health department throughout the state. So at least 159 locations can provide breast and cervical cancer screenings. In the health department, patients can access a clinical breast exam, a pap smear, and HPV testing. If there are abnormal results, those are referred out for diagnostic testing. Mammograms are always referred out. The program does cover those diagnostic costs. So the health department, I see it as standing in the gap for the uninsured or underinsured population. And we will see people with insurance too and bill insurance if they do have it, but if they don't, these programs are free or on a sliding fee scale to make sure there's access to this care for all patients of Georgia, regardless of their ability to pay. We also provide within the health department presumptive enrollment in Women's Health Medicaid. So what presumptive enrollment means is if an individual qualifies, and I have a slide that'll go through what eligibility looks like, they can presumptively get access to Medicaid coverage at the health department that day. They don't need to wait for clearance, and they have Medicaid coverage until DFACS approves their final eligibility. It's very similar to pregnancy Medicaid, where individuals can come to the health department and become presumptively enrolled and get coverage that day. So eligibility for this program. Individuals need to be uninsured or underinsured. We will provide these services to insured people, but will bill insurance. They should be at or below 200% of the federal poverty level. For breast cancer screenings, we follow the national recommendations, which are for women 40 to 64 years old. If there's an individual under 40 who is symptomatic, they have a lump or pain, we will do screenings for them in the health department as well. And then for cervical cancer screenings, those are for women 21 to 64. As I mentioned, the BCCP service locations, there's at least one in every county in the state. We also contract with some private providers to provide these services. The vast majority of them are in the metro area, other than Albany area primary health care, which is in this part of the state that we're in. And they do the same standards of screenings, eligibility criteria, and report that data to the state as one of our contracted vendors. So looking at the numbers of patients that we serve, you can see it hovers between 10 and 12,000 that are seen every year for breast or cervical cancer screenings, which has kind of stayed steady. It doesn't include the fiscal year 20 data, which was obviously during COVID when there was a lot of shutdown and lack of access to preventative care services. But you can see that we have kind of leveled off. That last year of fiscal year 25 does not include the complete year of data because we're not through with fiscal year 25 yet. So that number will increase. So looking at utilization, I know y'all love maps. You can see the areas of the state that have the highest utilization, which is nice to see in parts of North Georgia as well as South Georgia. And you can also identify areas that have room for improvement. There may be a lack of knowledge of the resources available. Especially in the metro area, there are a lot of providers where individuals may access services that are not the health department. This is just health department data. This slide is just for the breast cancer screening. This one shows cervical cancer screenings that happen at health departments, very similar. And I failed to mention, these occur in our family planning clinics, of which we have at least one location in every state. So our nurses that run the family planning clinics are trained to do these screenings. And then this last one is combined data of both breast and cervical cancer screenings around the state. So what do we do with diagnostic needs or abnormal findings? So our public health departments contract with private providers and outside facilities that are equipped to do more intensive screening that we don't have the equipment or training in the health department to do. So those are referred out to our contract providers if we have abnormal findings of that initial screening, and they can get this follow-up care, and the program does cover the cost of that. So there's not a patient cost to get the diagnostic screenings done or biopsies and things like that. This is the Women's Health Medicaid that I mentioned, where individuals can get presumptive enrollment. So the eligibility requirements are on the right side. So if an individual is diagnosed with breast or cervical cancer, so the program covers those costs up until diagnosis. After that, if they qualify, they can be enrolled into presumptive Women's Health Medicaid and get coverage for their treatment beyond that. And as I mentioned, final eligibility is determined by DFACS, but this makes sure that there's no gap in coverage and they can immediately go and start getting their care. So within the program, here are the numbers of women who were screened at our health department that had a diagnosis of cancer year over year, and then identifying the type of cancer that was diagnosed and identified by our health departments through this program. And then for legislative initiatives, there was funding in the fiscal year 25 budget to provide funds to outreach and about the breast cancer screening services to make sure that the constituents were aware that these services were available. The vast majority of that funding was distributed to our 18 public health districts around the state to conduct local outreach initiatives. A small portion was retained by our state office to do state outreach, which we used for a social media campaign, and a larger campaign is planned for next year, including postcards and a broader launch of outreach. So the second program I'm going to talk about is Cancer State Aid funding, or the Cancer State Aid program. This program does not necessarily provide direct services to the patients, but it does provide financial coverage for medical care. So this is exclusively funded with tobacco settlement funds, and it provides coverage for diagnostic and treatment services for eligible patients for any type of cancer, not just breast and cervical cancer. So how this, and I have a slide about how this works that we can go over, but as I mentioned, this program will cover the cost for the diagnostics for any cancer for someone who doesn't have insurance. So again, this is to stand in the gap for people that are either uninsured or underinsured. And we'll pay for the cost of their biopsies, imaging tests, treatment, as well as medications. So in order to be eligible, the individual has to be uninsured or underinsured and not eligible for Medicaid. The federal poverty limit income is 250% of the federal poverty level. And they have to be in need of essential cancer-related diagnostic staging or treatment services, or be receiving active treatment for cancer when they submit their application. And we work very closely in conjunction with those individuals' treating physician who help guide their treatment plan. They invoice the Department of Health directly once individuals are approved to the program, and we reimburse those costs. So in order to enroll, patients have to be seen by an oncologist that participates in our program. And I have a map I'll show, and certainly working to expand that network of hospitals and radiation centers that are participating in Cancer State Aid. We sign a contract with the hospital or the radiation center, and they're trained on how to help individuals get access to this program, so they can guide them appropriately. So once care is established, the facility staff helps a patient apply for this program, or the patient themselves also is able to apply. As far as our enrollment locations, this is the current map of our locations that we have a memorandum of agreement with to be a Cancer State Aid enrollment location. And like I said, we are working to expand this network. So if anyone's interested, please reach out to me. I think we have a part of the state over in the Augusta area that looks like quite a big hole that we could fill with one of our hospitals. So one of the things that we've done to improve this program is our IT system was a 20-year-old system that was the enrollment process for individuals. It was very cumbersome to use. So as part of our strategic plan for the entire agency, one of our priorities was improving our technology for this program. So we established a portal in October of 2023 for, it's a web-based portal for hospitals as well as patients to apply directly through that system. So that was launched in 2023. As far as the population served, this is the year-over-year data of how many patients have used this program. And I talked to our program leadership about, why is there a difference between how many have been approved and how many patients were actually served? They said during that time, individuals may get access to care through other means and not need to utilize the program. They may move out of state. They may pass away. There's a lot of factors that lead to that gap, but you can see how many patients are served and access this program now. And that is all I have for the 2 DPH programs on cancer services, but I'm happy to take questions and will do my best to answer them. If not, I will get you answers.
Thank you, Megan.
Yeah.
Are there any questions from the committee? If there are, it's sort of hard for me to see up and down. Just hit your mic button if you want to ask a question.
I have a question, Commissioner Andrews. the breast and cervical cancer program is critically important for our state.
Yes.
You mentioned that we get about 4.4 million in CDC and federal funds. Do you foresee any risks for that given the cut in CDC funding that's planned?
We are in a wait and see approach with most of our programs. So as Morgan and Chairman Hawkins know, more than 50% of our agency's entire budget is through federal funds. We have been receiving that grant for a long time, over 20 years. So we haven't heard any rumors or rumblings that it's going to be eliminated, but we are waiting and seeing what comes down. But at this point, it has not been cut, reduced, or eliminated.
Could I ask a question? Hi, I'm Devin Brown. I'm the president of PPMH here in Albany, Georgia. Could you go back one slide? Could you just speak to, it looks like there was a decline in the number of patients from 22 to 23. Any reason why you saw that happening? It looks like there was, some consistency 2020, 2021, 2022, and then the numbers seem to have dropped off. 2023, 24. I didn't know if you had any thoughts as to why you saw those declines.
I'd have to talk to the program and see if they implemented any changes. I know when the program used to have a requirement that there be a survivability rating given to a patient, and they had to have a certain rating in order to qualify for the program. I know that that was eliminated when Commissioner Toomey started in like 2018, which may have led to a jump at that point. So I don't know if there was a program change at that point that caused the decline, but I can certainly ask and get an answer back to the committee. Yeah.
Question here. Is there a monetary yearly cap on the Cancer State Aid program for individuals?
Well, no, not for an individual. Yeah, we have our budget, the 6.6 million, so, but we haven't gotten to the point where we've needed to cap it on a specific patient, how much the program can pay out. And I failed to mention, it does just cover cancer-related costs, so medication treatment. If they have other chronic conditions, it's not health insurance, so it doesn't cover those other items or issues that person may have. It's primarily focused on their cancer treatment and care.
I have a question. Very valuable programs. I think these have a lot of potential to be very impactful. Do you have any data on the repeat use? Because for this screening, for example, for mammogram, it's important to be doing it regularly. So do we know how often
Patients come
the
back.
women are really following up on the next necessary assessment?
Yeah.
And also, what percentage of the population is being covered? I mean, you showed us the numbers, but in terms of percentage of the population eligible.
Yeah, I can certainly have the program pull that data. One of the challenges we have at the department that we've been working on for a long time is we don't have a consistent electronic health record system across all of our health departments. So the way we pull this data is we poll every health department to go through their records and send us how many patients they have. So it is pretty tedious to get data pulled, but we are in the process of onboarding a new statewide electronic health record system. So all of the health departments are on one system, and we could much easier pull that data and look at unduplicated patients or how many are coming back for care. But that's, if they're able to pull it, I will have them pull that. Yeah.
Okay, thank you very much.
Thank you.
All right. Next up is Lynn Durham. She's with CORE. She's going to speak to the Georgia Cancer Plan 2024 through 2029.
Thank you, Mr. Chairman and the committee. I'm going to briefly talk about the Georgia Cancer Plan to let you know that Georgia does have a cancer plan and how we put this together each year. Thank you so much. So this is also funded through the CDC. I'm following right along with Megan Andrews and what she just told you. This is through the Department of Public Health as well. And the CDC gives money to all 50 states to develop cancer plans and to have 5-year cancer plans. So this was established in 1998 and covers all those areas you see. our leadership here in Georgia, and I have my two co-chairs here today, which makes me very happy, Dr. Brian Rivers from Morehouse School of Medicine and Sarah Sessoms from the Community Health Works Cancer Coalition in Macon. We work together with the steering team. Our leadership, I just wanted to point out, Dr. Chris Parker spoke to you last week and told you about their work at the Georgia Health Policy Center that includes this. And then Dr. Jim Hotz from right here in Albany, I have to shout him out because he has been with this program for over 20 years. And again, like last time, these are some of the organizations that come together on a volunteer basis to pull together the cancer plan. What we do is we write the cancer plan, we implement the cancer plan, and then we measure the cancer plan. And so we talked about the structure a little bit. So all these different areas and the round tables we have, colorectal, lung, prostate, and then these areas of survivorship, HPV prevention, early detection and screening, diagnosis, staging and treatment, and palliative care are the areas that the cancer plan focuses on. So this plan lives on the DPH website, and anyone can go and find the plan. We have this one from 2024 to 2029. So right now, our priorities for this plan are support cancer prevention efforts with a focus on HPV and tobacco use, detect cancers early and screen appropriately for target cancers, maintain excellence in the diagnosis and treatment of cancers, facilitate statewide access to palliative care and support, and improve the quality of life for cancer survivors. I think I mentioned last time, Georgia has over 610,000 cancer survivors out of a population of 11 million. So we have a lot of cancer survivors in our state. So I'm not going to go through all of this, but I want to show you what we do. So for each of these areas that I just mentioned, we have objectives, and then we work to implement those objectives throughout the system, and then we work to measure those objectives. I did want to point out on the first one there, supporting cancer prevention efforts with a focus on HPV and tobacco use. When we established that, at the time, the state was receiving money for the tobacco program. The federal government has recently just cut $2 million from the state for our tobacco use prevention program. And so that is a huge hole that we are trying to determine how we can help fill that. But I did want to make that point that those funds have gone away. And so unfortunately, we don't have that. But we will continue to work on HPV vaccinations and then also on tobacco use. And then as you see, just objectives through all of these. We really want to make sure that our group, our steering team, and the members of our working groups have these objectives to work through and to get assigned. Each meeting, we meet monthly and work through all of these. And then this is the last one. And then the report finishes with a call to action. And this is the first time we've done this. This is the fourth cancer plan that Georgia has had over 20 years. And this is the first time we've done this. And it's a call to action. And so you can see this is what can businesses do. But there's a page like this at the back of the plan for everyone, for individuals. What can community organizations do? What can schools do? What can healthcare professionals do? So we know this is not all on us as a member of a steering team. There's 30-some of us on the steering team. We can't do everything. But what we hope is that our organizations, our hospitals and others are working alongside with us to make sure that everyone understands what the cancer plan is and what they can do to work toward that. And that's all I have for you, Mr. Chairman. I just wanted to make sure the committee was aware that that existed. Any questions?
Thank you. Are there any questions?
Yes. Thank you.
Yes.
Incredible. I have a question. Does the Chamber of Commerce get involved in education in?
Not to my knowledge. We
Media?
haven't, no, not to my knowledge. I think there are certainly, my organization's a member of the State Chamber and other organizations are members of the State Chamber, but they have not become involved in the plan itself.
Okay.
No.
Thank you.
Mm-hmm.
Seeing no other questions, thank you very much.
You're
ma'am.
very welcome.
Appreciate it. Good job. Okay, next up is Robert Smith, Senior Vice President of the Early Cancer Detection Science American Cancer Society.
Thank you, Mr. Chairman. Members of the committee, I just want to say it's great to hear about the breast and cervical cancer program. I was one of the architects of that program when I was a staff epidemiology at the Centers for Disease Control. And in the beginning, it was only going to be a cervical cancer program. And we said, when you look at the distribution of these cancers, why wouldn't we take this opportunity to really give this emerging program of breast cancer screening a shot in the arm by making this a program for both of those two cancers? So I'm charged with talking with you about the economic impact of cancer. Most of the data that I'm going to be showing you today are for the entire country. Everything I'm showing you relates to every single state in this country. And just to begin a little bit with the paradigm shift that we had at the beginning of this 20th century, in terms of Kuhn's notion of what is a paradigm shift, this truly qualifies. In the beginning, we thought of cancer as a systemic disease at inception that appeared, more dominantly in one or more organs, because most cancers were detected late. But it became pretty clear, the more we studied cancer, that cancer actually was localized at inception and became systemic as it spread. And that gave us the idea that if we could detect cancer early, essentially if we could diagnose cancer at the first sign of symptoms, the observation was that the prognosis would be better. And then a light bulb went off in people's head, and they said, well, if this cancer has been around to the point where it produces symptoms, it certainly has to have been around a long time asymptomatically. And then the goal began to try to detect cancer before symptom developed. And even to this day, we have to continually remind people that cancer screening is not for people when they have symptoms. Cancer screening is when people feel fine, they don't feel sick. There's no reason perhaps to think that they need these tests, and that's when they need them the most. So work began on this fairly early, and the American Cancer Society, which was established in 1913, embraced early detection very early in its history. We began promoting the use of the pap smear in the 1940s. I won't say many of you, some of you in this room are old enough to remember the TV ads about the 7 warning signs of cancer. And this is John Wayne, who did some of those ads and also talked about his own cancer on television. And so you can see that cancer screening, as we know it today, really took off in about mid-century, with the pap smear in particular. And the American Cancer Society had produced the first evidence-based evaluation of cancer screening in 1980, when we subjected all of our guidelines to this new movement to actually have a scientific foundation for everything we do in medicine. So this is kind of what we try to accomplish with cancer screening. And as you can see, you have a sort of a display of the natural history of the disease, from no disease through preclinical disease and clinical disease, and then unfortunately oftentimes cancer-specific death. But we have the tools actually to deliver prevention and avoid the disease from ever developing, finding it early, to intervene early so we can have better outcomes from the disease, and the progress we've made in treatment that can overcome the trajectory of cancer to death through these chemotherapies, radiation therapies, all the therapies that are evolving so rapidly that especially make a difference when cancer is advanced. So this kind of busy slide, and no one would produce this unless they did it by hand like I did. So you can see, in fact, how much better we do in 5-year survival with conventional measurement here when we find cancer early. All those tall columns to the left in each of this top row show the survival when we can diagnose cancer at a localized stage compared to regional stage or distant stage, when prognosis is typically and survival is much, much worse. Now, the bottom row shows you how well we're doing at diagnosing cancer at these stages, the more favorable stages versus the worst stage. And in each instance, you can see those columns on the left are shorter. And in some instances, the middle columns, regional and distant disease, are taller. And this tells you the challenge that we still have, because even when we look at our rates of cancer screening today, in the US, unfortunately, we mostly measure cancer screening based upon self-reports from 2 national surveys, both administered by the CDC. And those self-reports are like many things in surveys, they overestimate how much cancer screening we do. What they also measure is cross-sectional screening. What's that? What I mean by that is essentially you answer the phone, you agree to answer the survey, and you are asked, well, when was the last time you had your cancer screening test? That gives the impression that this is the rate of adherence we have with cancer screening all the time. But people cycle in and out of cancer screening. Everybody in this room who has had cancer screening has almost certainly experienced missing an appointment, letting time go by between your screening examinations. It's quite often to think that's not a particularly big deal, but I take you back to what I was saying earlier. You're asymptomatic. You have nothing to worry about, so you're imagining that you'll get around to it, you're committed to it, but things come up. So we are very, very challenged to try to not only promote cancer screening, but to promote regular cancer screening, because it makes a very big difference in outcomes if you unfortunately do develop cancer. So to the point of this particular presentation against that background, I'm going to show you the costs of cancer, and then I'm going to show you the economic benefit from early detection. It's no secret that healthcare costs are going up, and the healthcare costs of cancer are going up as well. These are projections, but you can see that we've had a 34%, we project a 34% increase from 2015 to 2030. These cancer costs are rising by billions of dollars every year. It has a tremendous impact on society, and it also has a tremendous impact on patients and survivors. It has a huge impact on employers. In fact, employers tell us that cancer is the top driver of their health care costs. 66% of individuals with cancer and survivors say that they have missed more than 4 weeks of work due to their illness. 39% reported missing more than 3 months. The costs of cancer are particularly high among people under the age of 65. And the healthcare expenditures to companies for patients average $16,000 to $20,000 per year. Those are very, very large numbers. Before we move away from this slide, I want to emphasize the cost to the monthly health premium of prevention and early detection. It's not too exaggerating to say it's pennies compared to everything else. It's a very, very small amount of the total corporate burden of cancer care. The big burden is the cost of treatment in people who get cancer. For individuals, cancer is the leading cause of medical debt. 47% of cancer survivors incurred medical debt in order to pay for their cancer care. These are people who typically had insurance. Those with cancer debt are more than 3 times as likely to be behind on cancer screening. This is an interesting thing, that debt is kind of oppressive with respect to meeting other healthcare needs. And I think these 4 little statistics over to the left here, the thing that really struck me when I looked at this slide is that 55% of people report that their debt has gone to collection, and almost half say that their debt has hurt their credit score. These costs are particularly high for working age people, and the average annual healthcare expenditures really dwarf normal health expenditures. You can see these 2 indications for people that were below Medicare age and people above Medicare age, and it's still quite high for each group. I mean, many times higher than normal health expenditures. But you know, one of the things that has frustrated me as long as I've been in this field is all the costs of cancer that we don't have an easy time measuring. It's very hard to put a dollar amount, but as you look over this slide, you know immediately what I'm talking about. When people develop cancer, immediate family members, first-degree relatives, a little outside of your family unit, relatives and friends, the effects of a diagnosis of cancer ripple through your individual community, and they can be long-lasting. In the workplace, we always tend to measure absenteeism. We put a huge emphasis on people missing from work. We don't put as much emphasis, but more and more we're starting to do this, on presenteeism. You're not at your best. And productivity, and there's productivity loss. Now, each of these things doesn't just apply to the person with cancer. If you're a caregiver, it influences you also. If you're someone in the workplace, it can influence you, you know, because there's an emotional toll to a close colleague being sick and absent. It's not only patients that are affected by absenteeism, presenteeism, and productivity, but caregivers, family members, coworkers, and friends. We don't have an easy time measuring that. When we lose in the workplace somebody, a valuable employee, we might not ever make up that loss. They might have been so important to many aspects of the workplace that their loss will be felt, you know, forever. For those that we can make up, it can take many years to bring that person back up to the experience and the skill level that they not only bring to their own work, but that they pass on to others. There we go. The cost of avoidable disability and premature death from cancer are extended to cost to families and communities. So when you have the premature loss of a family member, it can have lifelong costs and diminish not only financial, but it diminishes quality of life. You can think of the loss of a spouse, the loss of a sibling, the loss of a parent, the loss of a grandparent. You can think about the roles that each of these people play in running a family and supporting a family. Grandparents in particular to young families. And the loss of economics to the community, we have a hard time measuring that, but just imagine the average number of years of life lost to a death from cancer, and this is average, is about 15 and a half years. That's that many years of somebody no longer being in the community making an economic contribution. Think of all the economic contributions we make every single day. You know, we fill our cars up with gas, we drop our clothes off at the dry cleaners, we go to Home Depot over and over in the same day, going back to get things to work on a house or something like that. And of course, we contribute in our work. We don't measure these very easily, but they are very, very real. So now let's look on the bright side. Is cancer screening cost effective? Cost effective analysis is complicated to do because it's really modeling. You're basically applying the cost of everything you're doing in cancer care and screening and prevention and measuring it against what you gain in terms of life years gained, quality adjusted life years gained, disability adjusted life years gained, all of these measured. What I can tell you is that what always comes up is a favorable benefit. When we say something is cost effective, it means essentially we're willing to spend that amount of money for what we measure as a value for a life saved, a year of life saved, a death prevented. But in fact, in some instances, cancer screening can actually be cost beneficial, which means it actually returns a financial value to the state or the community. Now, this is an estimate, paper just came out recently, of the deaths averted from prevention, screening, and treatment efforts in our fight against cancer. And from 1975 to 2020, we estimate that we saved approximately 6 million, prevented 6 million premature deaths from cancer through the combination of screening, prevention, and treatment of diseases. But of that gain, 8 in every 10 deaths averted from breast, cervical, colorectal, lung, and prostate cancer over the past year, 45 years, was due to prevention and screening. A big chunk of that, of course, is getting people to stop smoking or not start smoking. But, you know, we take everything we can get, you know, in the fight against cancer. Early detection and prevention is associated with much lower treatment costs. On average, an early diagnosis saves 20 to 30% of the treatment costs of a late-stage diagnosis. So in effect, anytime we think about one of the things you're going to gain from finding these cancers early is a big savings in the cost of treating the disease. The aggregate value of cancer screening can be judged to actually return a benefit when you apply the value of each of those years of life saved to the number of years that you have gained. Here's an estimate roughly from the period since 1996 of the years of life gained as a result of cancer screening. And down at the bottom are a range of estimates of the monetary gain, with estimates also for how much greater that gain would be if we had full adherence to regular cancer screening. And it sort of equates to the worthiness of pursuing those goals of having higher rates of cancer screening, because when you do, you are going to have better outcomes. So this is actually gets to the point of what do we need to do. We've achieved a great deal, but there's vastly more work to be done, which is why we are here today. Now, when I look at this, and I hate to bring up when I compare what our colleagues in Europe do, in the U.S., healthcare is not organized. Screening is not organized. At the American Cancer Society, when we start thinking about all the problems we face, the first question that you want to bring up is, who's responsible for solving that problem? And the answer, if we live in the U.S., is that you can't really point a finger that any particular organization is responsible. They're all interested. And in fact, if you recall Lynn Durham's slide that showed all of the organizations in Georgia that come together to contribute to the cancer plan, all of the scientists and physicians and social workers and other healthcare personnel that give freely of their time to try to make things better, come together and actually make those kinds of contributions. They take on that responsibility. So when organizations like Cancer Corps, the Health Department, the American Cancer Society, and others call on us to come together to help solve a problem, we show up. I mean, we are doing this for, our population, our state, and so on. But these problems are orphaned. We can't really point to any one organization having a responsibility for them. Except for colorectal cancer screening, rates for other cancer screening are flat or declining. This is especially troubling, and it's been this way for the past decade. Regular cancer screening rates are not optimal, and that's when I was telling you people cycle in and out of cancer screening, which is not a problem if you don't have cancer, and it can be tragic if you do. And many individuals face barriers to screening and follow-up, especially the uninsured and people living in rural areas. We just published a paper recently that showed that 95% of the population that is eligible for lung cancer screening live within 40 miles of an imaging facility. If you live in a rural area, 25% of the population is further away than 40 miles from an imaging facility. And I always like to remind people that that may not seem like a big deal if you live in a flat state like Texas, where long driving distances are not such a problem. But in the East, not so many people drive 40 miles for preventive health. They will for their therapy, but not necessarily for preventive health. So the existing infrastructure in the state needs resources and support. And this is not commonly a large amount of support. A lot of the support simply is the need to have a few staff that can carry a load to support all the volunteer efforts. The American Cancer Society, again, addressing these orphan issues, has established cancer roundtables. Our first one was established 28 years ago, and we have promoted states adopting mirror image organizations, because all of the challenges at a national level are the same challenges at state level. I can tell you Georgia leads the nation in establishing state-based roundtables. Not only, I think they have the largest number, 3, but they established them first before any of the other states, so hats off to Georgia. The Georgia Department of Public Health supports the Georgia Cancer Control Consortium, GC3. Again, a lot of volunteer effort going into developing that state cancer plan, working with how we can improve cancer care in the state. Georgia Corps does terrific work in organizing and establishing programs that support cancer control. Primary care providers everywhere are stressed, and we need to find ways to support them and to provide incentives for them to do the very important job they do of referring their patients to regular cancer screening. And that work in federally qualified health centers is especially stressed. So I really want to emphasize that every part of our cancer control effort is important, but prevention and early detection is the cornerstone of better outcomes. I'll give you one example of a program that we developed and applied in some states, and it works really pretty well. One of the leading causes of death from colorectal cancer is not being followed up after you've had a positive examination. And that is a particular problem for people who get stool testing, which are more commonly lower income populations. Oftentimes they can't get time off for work to get a colonoscopy, they can't get an appointment to get a colonoscopy, they live a long distance away, and they don't have the insurance coverage for it. We at the National Colorectal Cancer Roundtable and the Georgia Roundtable did this also, and tried to enlist care, free services from GI practices, and there was a lot of pushback because they just imagined that they would be overwhelmed with uninsured people, and that their own experience thus far had been that, yes, we said we can do these examinations, the patient doesn't show up, they don't show up prepped, it's a big time sink, and it's just not workable. So we promised that if they would just agree, we would spread the burden across the community. If they would just agree to do one a month, we promised to deliver a patient prepped and ready to go on time. And they said, if you can do that, then we're in. And shortly after the program had been running for a while, we started hearing, you know, we can do a few more of these a month. That's not a problem. Because they're thinking, how much better for us to address this challenge of determining whether the patient has cancer and ideally treating them early than much, much later, when it will be much more difficult and much more expensive. This is the kind of program that, with enough support, you can further enlist the contributions of your community clinicians and achieve a benefit for people who otherwise are not going to have it. I believe that is my last slide. Okay, thank you very much.
Are there any questions? Yeah, go ahead.
Thank you. Thank you, Dr. Smith, for that presentation. You talked about Europe being more proactive than we are in the United States. What country has a better presentation for doing screening and things in Europe?
Yeah, I'm sorry to bring up Europe, but
No, it's.
But here's the thing. Sweden does. I mean, these Scandinavian countries are unique. I mean, they're small, very homogeneous. They have very strong healthcare systems. What's important about their healthcare systems is that they're organized. So it's not, in the U.S., cancer screening is a coincidence of encounters and an interest between patient and physician. When we ask people why they got a test, the first thing that they say, the most common thing, is my doctor told me. When we say, why haven't you had this test? They'd say, my doctor hasn't told me to get it. We, in Europe, separates the cancer screening from the general practitioner. It's centralized. If you're eligible for screening, you get a letter with an invitation, very commonly an appointment. If you can't make that appointment, you can call and change it. If you have a positive test result and that system does not get a report that you've been followed up, they follow up with you. They have higher rates of regular attendance, and that makes their cancer screening programs more productive. They also evaluate them. They have quality assurance measures that they measure to ensure that the quality of cancer screening is high. It's just a much more sensible arrangement, but it's not something we have in the U.S.
What can the legislature do to help provide or assist in the screening process? What can we do at the legislature?
Yeah, it's a good question. It's the right question. So I would say that placing an emphasis on high rates, on the importance of high rates of cancer screening is a very first step, just that commitment. I don't recall ever having heard a State of the State or a State of the Union address where health was brought up. And I think it's very important to create a spirit of achieving better health. I would like us to have ways to kind of impose organized screening in a system that's not organized. If we could promote health systems, for example, to take on these call-recall systems and relieve the primary care provider of the burden of tracking and using time that they oftentimes will say, I don't have with this patient. They came in with an acute problem. It's the only time I've seen there was really no time to talk about cancer screening. Electronic health records need to do a better job of maybe helping the primary care provider identify who is behind in cancer screening, who is due for cancer screening, who hasn't been followed up for cancer screening. The more we can organize these systems to track really the leading cause of death before the age of 85 in terms of the risk of cancer, I think the more progress we would make.
Any other questions?
Yep, I have one question. Bob, in 2020, we saw a dramatic reduction in number of people going for cancer screening as a result of the pandemic.
Yes.
The colonoscopies and mammographies were down 50 to 80%. What are you seeing now, 5 years later? Are we down to or back to the pre-2020 levels? Are we making any progress there nationally and specifically in Georgia, if you have any data?
Yeah, that's a great question. We've studied this a lot. In fact, there's a ton of articles in the medical literature on what happened and have we recovered. And what happened was, it was pretty devastating. And frankly, it was the well-intentioned advice to don't come to the health system if you're not sick, and postpone cancer screening because it's not urgent care. And it turned out that that advice was wrong. It is urgent care. It's urgent if you have cancer and you don't know it. So we saw a big drop in procedures, a big drop in pathology. We saw that we were have steadily been recovering, and we have recovered across several of the cancers. We have not completely recovered for colorectal cancer. Ironically, the drop in colonoscopies was overcome by the increase in stool testing, which was a very good sign. And sort of like to have more people get stool testing anyway, because more and more colonoscopy services are stressed, and it's taking a long time for people to get into them. But the systems are what are going, but our federally qualified health systems have not recovered from all the progress we made. I mean, they are below the 2019 rates. So more effort has to be. You know, it took a lot of time to get people into screening that had not been screened, and then when we pushed them away during the pandemic, we're going to have to start this process all over again.
Any other questions? Yeah, go ahead.
Dr. Smith, your last slide, you mentioned how primary cancer care providers are extremely stretched right now. I've heard low numbers as to the number of graduates coming out of Georgia medical schools that actually go into oncology. In your experience with the American Cancer Society, have there been any states that have come up with any kind of interesting plans to encourage more physicians to specialize in oncology that you're aware of?
Yeah, there are state and federal programs that normally, it's not just general primary care, it's that you would have, there could be some forgiveness of your medical school loans if you were willing to practice in a setting that serves low-income individuals or in an area that is underserved. And I think that helps somewhat, but I think people go into so much debt in medical school, and frankly, primary care provider salaries, you know, and pay is considerably lower than that for specialty care. And I think it's just too many people move on to specialty care or choose to go into specialty care because it pays better. And I think and we're seeing actually that our
I do have a question, follow up, you know, the point you made about prevention of cancer and how economically there's pennies on the dollar, you know, to prevent cancer rather than treat cancer. And you mentioned one way in terms of prevention, in terms of decreasing smoking, and children also focus on maybe vaping as well. But could you comment on other lifestyle changes, opportunities for prevention related to diet, obesity, health, fitness, and things like that, opportunities to really get at the core of things that might have impact on cancer incidence?
It's a very good point. These things go hand in hand, right? Because you can't decide you're going to, well, some people might, I'm going to choose a prevention path and I don't have to do all these other things. You know, we have to do them both. But, you know, literally everything that is associated with our leading chronic diseases shares a lot in common. And that is that it's important to be physically active. It's important to eat a healthy diet. It's important to maintain. I get a lot of laughs when I say this. The weight you had when you were finished high school, that's not even so ideal anymore since obesity is, you know, stressing into the younger population. We know that if you drink, you should drink in moderation. We're not going to really be very persuasive to people who enjoy drinking alcohol to stop. But I think many people probably are aware that the portions we're getting are growing, you know, and if you can get people to be adherent to moderate consumption of alcohol, it's not it's a significant contributor, but it's the larger volumes that contribute the most. And again, it's just part of a healthy living package. Getting enough sleep, you know, is important as well. So all those things are going to not only contribute to a lower risk of cancer, they can contribute to a lower risk of cardiovascular disease, diabetes, and, you know, and other leading causes of premature death.
One of the reasons I mentioned that is in children, not only is it you know, obesity and lifestyle increasing potentially incidence of cancer, but also decreases some of the efficacy of the treatments that we have. So in some cases, obesity makes children less responsive to the cancer treatments that we have to offer.
Yeah.
This is very valuable information, and one other aspect that plays a role in this screening and prevention is genetic predisposition. Of course, that's a much more complex thing to achieve, but those are individuals that are at particularly high risk and may have more needs for screening and prevention elements. There's, of course, the availability and cost and all of that, so that makes it a little bit more complex. What role, if any, should that play in our approach to expand screening and prevention?
Yeah, we were sort of on the cusp, I think, of thinking about that, whereas in the past it would have seemed unaffordable and it would sort of violate the premise of not doing something to a large number of people that would only benefit a small number. One thing we see right now, using just simply the crudest tool of measuring and acting on family history, is our performance is terrible on that. There was a recent study that showed that simply in colorectal cancer, acting on the family history and beginning screening early would identify 1 in 4 early colorectal cancer cases at a point when the cancer would have been found very, very early. And yet we do a terrible job in that. We have people who have incidentally gotten genetic testing and ancestral testing, things like that, and discovered that they are carrying a mutation on one or another susceptibility genes. So as we enter into an era of personalized medicine, we're celebrating all these great gains we could have in estimating risk. We should take advantage of that, and, you know, so people can tailor their preventive health to that new information. I mean, we get an anecdote, you know, very commonly. You know, I did not know that I was carrying a breast cancer mutation gene. Our family histories oftentimes are just not very cooperative. We don't have the visible way of seeing the tumor phenotype because we just don't have families where they show up. So we really might get to a point where it would make sense to do this kind of genetic testing. And there's a lot of work going on this, and, you know, as a matter of course. You know, I'm a big fan of checkups. I mean, checkups are a way to have more time with your primary care doctor to cover your broader health needs. In other words, you can say it's unrealistic for them to do everything they need to do in these short visits. We all know what those visits are like. There's one hand on the doorknob as they're getting ready to go out the door because they've got other patients waiting. But a checkup, especially if it's structured, can do a cancer risk assessment, and in a way that would be beneficial.
Okay, well, thank you very much.
It's been my pleasure. Thank you.
Thank you. Okay, up next is Nita Ham with the State Office of Rural Health, serving rural Georgia.
Thank you very much. I really appreciate the opportunity to be here today to share with you about our office. And after hearing the earlier presentations, I feel like that my presentation is going to support much of what's already been stated. I am Nita Ham, the Executive Director of the Georgia State Office of Rural Health, and I will just tell you a little bit about who we are and what we do. Our office was actually established in 2000, so we're coming up on our 25th anniversary. We are a division of the Department of Community Health, and we're actually located in Cordele, Georgia, which is in Crisp County, one of our rural counties, and just up the road from here. We have a very small but mighty staff of 10, and within the SOAR office, we have 4 program sections. We have the primary care office, the SOAR program, hospital services, and the farm worker health program. So just to give you an idea of what we do, what our primary responsibilities are, we administer federal and state-funded grant programs that are designed to increase access to quality care, improve the quality of healthcare services, and promote the health and well-being of rural residents. And I know you've seen some maps earlier today, but this is one of my favorite maps because it actually illustrates very clearly how much of Georgia is rural. So Georgia defines rural as counties that have less than 50,000 population. Out of 159 counties, we have 120 that are defined as rural. So you can see that most of Georgia is rural, and just about all of the southern half of the state is defined as rural. So if you look at the definition across the board, the U.S. Census Bureau defines rural as regions with low population density, sparse building and infrastructure density, and dispersed land use patterns. And I included this picture because I live in Cordele, and on the way to work, this is pretty much the scenery between my home and my office. If we look at Georgia compared to the United States, just over 15% of the U.S. population resides in rural areas, covering about 72% of the landmass. But compared to Georgia, we have about 21% of our residents living in rural areas, and it's about 75% of the landmass that's rural. Again, 120 out of 159 counties. So we have a lot of challenges in rural Georgia. If you look at just about any data, it will paint a pretty bleak picture of rural life. So while these are certainly not all of our challenges, I did want to highlight some of the challenges that we have in rural areas that are specific to this conversation today. So one of the things that we're faced with is declining population in rural areas. Also, those remaining residents are increasing in their age. So we have an increasing number of residents that are 65 years or older. We have, as been mentioned earlier, higher number of uninsured or underinsured residents. And then across the country, the conversation continues that we have a lack of access to primary care. There's also the threat of rural hospital closures that we deal with every day. And then one huge barrier to care is transportation, and I'll talk about that in a couple of minutes. Other issues that we deal with, obviously the higher prevalence of chronic disease such as cardiovascular disease, stroke, diabetes, pulmonary disease, and of course cancer, as we're discussing today. We have higher rates of obesity, higher rates of tobacco use, and poor nutrition and food deserts across our rural areas. So to talk about what our office does on a day-to-day basis, a day in the life of the SOAR office is basically this. We have a very dedicated team of health professionals that are passionate about the work we do. We only have 10 staff. Of those 10, 8 of the staff members actually were born and raised in rural Georgia. I'm one of only 2 that is a transplant. I moved from Atlanta about 12 years ago to take this position, and I'm thoroughly invested. I am a 100% country girl now. So I love living in rural communities in spite of all of the challenges that we face. So on a day-to-day basis, we manage 6 federal grant programs for which the Department of Community Health, SOAR, is the grantee. Those funds provide funding for our office administration, staff salaries, and then subawards for specifically designated programs. We also manage multiple state-funded grant projects and programs. We have a wide variety of grantees with a wide variety of specifically designated use of funds. And just to give you an idea of that, when we started fiscal year 25 in June or July of 2024, we had 89 active grants that our office was managing. We also, on a daily basis, are focused on rural hospitals. That's in our face every day. We manage the Rural Hospital Stabilization Grant Program, and the purpose of that funding is simply to prevent rural hospital closures. So Georgia's had 11 rural hospital closures since 2001, and 8 of those were actually between 2013 and 2020. We are now entering the 10th year of annual funding. The state has invested over $52 million into this program. We've had a total of 78 individual awards. 38 of our rural hospitals have participated in the program, and obviously you can tell some of them have participated more than once. And again, our goal is just to keep those rural hospital doors open. If we, looking specifically at rural hospitals in Georgia, we actually have 68 rural hospitals. 37 of those are PPS hospitals. We have 30 critical access hospitals. One of those critical access hospitals actually resides in Effingham County, which is not considered rural, but we still work with that hospital because of its COD designation. And we have one rural emergency hospital in Irwin County. We have 54 counties that do not have hospitals. So this is the my favorite map that's overlaid with the locations of our hospitals, as well as the counties that do not have hospitals that are identified with the red X. I'm certainly not here advocating that every rural county needs a hospital, but this map tells a lot of different stories. And one thing to notice is the cluster of counties that have no hospital at all. So certainly access to care and distance to care is greater in those areas of the state. And then we have, especially you can look in the lower southwest quadrant of the state, we have counties that have a hospital in every county, and that in itself has its own challenges. So we certainly are constantly evaluating this map, evaluating these access to care, and trying to fill the gaps as best we can for those clusters of counties that do not have a hospital. So just to give you a little idea about our 4 program sections and what those program sections do on a daily basis, I'll start with our primary care office. So the primary care office has the responsibility for the state for designating the health professional shortage areas and the medically underserved area and populations. And these designations are extremely important because this ensures that those areas have access to state and federal funding that can help to address their specific needs. So if we look at the types of shortage designations that we identify, we have the health professional shortage area, dental health professional shortage area, mental health professional shortage area, and then that designation for the medically underserved area and populations. Once there's a formula for the designations, and those formulas arrive at a score. The scores are between 0 and 25, and the higher the score, the greater the need for a primary care physician. So certainly this is a very important role of the primary care office at SOAR. Also, they work on health care workforce issues. As we were just talking about earlier, we manage the National Health Service Corps program. This is a federal initiative that's designed to help those health professional shortage areas that we've identified with recruiting and retaining physicians and other allied health professionals by offering loan repayment programs and scholarship programs. So just to put some numbers to that, we have 487 approved sites in Georgia out of the 142 out of our 159 counties. And in fiscal year 24, there were 128 National Service Health Corps awards that were distributed around the state, totaling almost $7.5 million. Another primary responsibility of the primary care office is the J-1 visa waiver program. So this is a state and federal partnership. Our program sponsors 30 international medical graduates every year, and as a participant in this program, those physicians agree to practice for a minimum of 3 years in one of our health professional shortage areas after they complete their residency. So this is a 3-year program. So for the current 3-year focus that we have, we've placed 18 primary care physicians and 72 specialists. Just a interesting little twist. The former director of our primary care office was actually diagnosed with cancer last year, and she is currently seeing an oncologist here in Albany that she placed through the J-1 visa waiver program. Another thing that I just wanted to mention is all 4 of our program sections do manage grant, both federal and state funded grants, but I did want to tell everybody that the primary care office manages grants to the Georgia Primary Care Association to foster the development and expansion of federally qualified health centers. So I wanted to bring this up today because FQHC plays such a crucial role in preventive services, access to screenings, providing patient navigation, and addressing social determinants of health that impact cancer care. At the moment, we have 6 active grants with Georgia Primary Care Association that are totaling about $1.25 million. Every year, we get state funding through the state budget to add another round of funding for GPCA that specifically designates those services to be provided in an identified area of the state. The second program section I want to mention really quickly is the SOAR program section, and that actually primary responsibility is to manage the SOAR federal grant. So that there is an office, a SOAR office in all 50 states, and there are 3 primary core objectives for that SOAR program: to collect and disseminate information, to coordinate rural health activities in the state to avoid redundancy, and of course the provision of technical assistance. Another thing that's an ongoing responsibility is that we just stay connected with our rural communities, especially with those healthcare providers and healthcare access points. The SOAR program section actually manages the majority of our legislatively directed funds. We average any year between 20 to 32 of those funds that are managed through that program section. And I did want to call out a couple of the grants that we do manage, and I think our grantees are here today. We do provide annual funding to Georgia Core, and their initiative is specific to breast cancer education and screening and treatment. And then we also provide funding to Horizons Community Solution every year. And of course, their focus with this funding is to raise awareness, provide direction to appropriate resources, and education on cancer prevention and navigation. So we're very proud of that continued funding for those 2 grantees. The Hospital Services Program section also manages 2 federally funded programs. One is the Medicare Rural Hospital Flexibility Program that we refer to as our FLEX grant, and those funds are for specifically identified initiatives to support our 30 critical access hospitals. And then we have a small rural hospital improvement program whose purpose is to assist hospitals with 49 beds or less in some specific training, especially to improve their financial status. So just to let you know that those are the 2 primary programs that Hospital Services administers, but I did also want to point to one of the initiatives with the FLEX program. It's a 5-year initiative that has just started to improve colorectal cancer screening rates for eligible patients that are in a cohort of 3 critical access hospitals that have been selected for that particular program. So those 3 critical access hospitals have attached rural health clinics, and so that's the initiative was launched there, and then we're hoping to have some good numbers at the end of the 5-year, this 5-year initiative. The last program that I'm going to mention that we manage is the Georgia Farm Worker Health Program. This actually is a 30-year-old program, so it's even older than our office. And we provide funding through that program for primary health care services for our farm workers. And of course, those of you who are familiar with rural recognize that those farm workers are in the fields from sunup to sundown, planting and harvesting the crops that put food on our table. So they're very important to us. We provide funding for 6 clinics, which are color-coded there, and a total of 21 counties that are impacted by this particular program. In calendar year 2024, we actually had almost 12,000 patient encounters through those clinics. They have not only fixed-based clinics, but they also have mobile clinics that takes the healthcare out into the fields or into the communities so that it provides easier access for those. And again, I wanted to call out an initiative that they have ongoing right now, which is to increase access to colorectal cancer screenings. And then, of course, those primary care clinics will connect those patients who need further screening or treatment with those resources. So I did want to circle back around to the transportation challenges. This is a big conversation that goes on across the country every day in rural areas, and we've already sort of touched on how distance and access to care impacts cancer care. But this is a little snip from some research that was published in April of 23 that basically just says in our rural areas, transportation plays a big role in the challenges for patients to get to their primary care, get these screenings, and certainly to have any kind of ongoing follow-up care that may be needed. Unfortunately, what we see a lot of times in rural areas is these transportation challenges result in patients terminating their care early. And unfortunately, that drives up all of our poor outcomes because, and that's just so sad that they simply cannot get where they need to go for their treatment. I think it would probably be wrong of me not to mention, since we've talked so much about dollars invested, that we are, as I mentioned, a division of the Department of Community Health, which also manages our Medicaid program. So I will not try to even explain what the Medicaid office does, but I will tell you that if you're interested in some information about the different programs that are offered through our medical assistance plans, or if you're interested in any of the dollars invested in cancer care in our rural areas, we can certainly connect you with those folks that can get that information for you. So the last thing I want to do is just say, how can our office be of help to this group and this particular initiative? One of the things I think that's important for us to do is to continue doing what we do on a regular basis. We'll stay connected with our communities. We try to determine what are the new challenges that they're having. And one thing I have learned is that no 2 rural communities are alike. They may be alike in size or geography, but there's all of their challenges are very different, and so it's almost individual evaluation and determination of what these counties actually need. So we will continue to administer our programs to support rural health care needs, and as always, we constantly evaluate the effectiveness of our program and recommend changes when necessary. And then we will continue on ongoing effort to increase access to primary care, keep our rural hospitals doors open, and then continue to address our workforce issues. We're always available to help. We're prepared to take on new initiatives if that's necessary. We bring our healthcare leaders together. So as the frontline folks that are faced with the challenges of delivering healthcare, we bring them in. So, is my time up? That's the hook. Okay, I'm almost at the end. But we definitely are continuing to bring our leaders together, healthcare leaders together, so that they can help us determine what the needs are and offer solutions. And certainly they want to participate in these solutions. We'll continue to participate in work groups and committees like this to look at and other programs that are available to us so that we can provide input on rural needs, and then we're always available to manage new initiatives or funding as requested. As I mentioned earlier, our office does a really good job with that. So I've provided my contact information on this slide. I also brought in my partner over here, Grace Finney, who is the legislative liaison with Department of Community Health. So if there's anything that either of us can do for you, you have our contact information, and we stand ready to respond to whatever your requests are. Thank you.
I would like to ask you a question, Nita. You're talking about keeping rural hospitals open. What was the cause, or what is the continuing cause of our closure of rural hospitals, in your opinion?
Money.
Okay.
As we've mentioned, healthcare costs are going up, and reimbursement is dwindling, and the cost of providing services is just more than what most of our rural hospitals can sustain. Many of them are reducing service lines. They're trying to direct the focus on the service lines that are the most critical to their communities. As I pointed out in the map, we have a lot of hospitals that are in neighboring counties, so they are learning to partner together so that they're not all offering the same services. They're sort of dividing up who will do what so that they can capture the market share, as well as continue to provide services in a reasonable driving distance. So they are doing everything they can to try to stay there for their communities.
So you mentioned reimbursements are going down. Which reimbursements? Are you talking about third-party payers, insurance? You're talking about Medicaid, Medicare?
But all of the above.
All the above. Do you foresee any more hospitals closures in the future from our rural hospitals?
Unfortunately, every day we are concerned that we may have another closure. The last one that we had was in 2020. Although we are heavily invested in the work that they do, and we certainly are concerned that there may be one or two more in the near future, as sad as it is for me to say that.
I know this study committee, and especially our committee for healthcare at the CAP, will be very interested in any kind of report you could give us on how to approach this problem and help them.
Absolutely.
I'd
Be glad
appreciate
to do that.
Thank you.
Thank you.
Any other questions from the committee?
I have a question. So first off, great presentation. Your passion for your work shines through. I have a two-part workforce question. The first being physicians that are sponsored on J-1 visas for 3 years. What's the retention rate after that?
I have those numbers, but I don't have them memorized. We have many of those 3-year programs that it will extend to 5, but we do have a great retention rate, and I'll be glad to get the exact numbers back for you.
And then the second part of that, I know a lot of schools in the state have increased focus on rural areas and educating people coming up, physicians, other providers. Have you seen that translate into getting people in rural areas?
Absolutely. What we do know, especially, is if you're raised in rural, you're more likely to go back to rural to practice. Second thing is if you train in rural, you're more likely to go back to practice. So we have increased the number of residency programs around the state that actually sit in rural areas to encourage those residents to practice medicine in rural areas. And the State Office of Rural Health has kind of gotten into the graduate medical education business too. Yep. Last year, we had our first round of funding to support new rural residency programs, and we've gotten that funding again in this round of funding. So we're very excited to be encouraging those new graduate medical education programs in our rural areas in hopes that attracting those residents into rural areas for their training will result in them deciding to stay. It's a great place. It's a great place to live.
Okay, well, thank you very much.
Thank you.
Seeing no other questions, let's go ahead and take a 10-minute break and meet back at, say, 10:50. Let's meet back at 10 till 11. Thank you. If we could begin getting our seats, and we'll go ahead and start the second part of our presentations. Okay, thank you very much. And next up is someone that probably needs no introduction. She's been around for a long time. Kaylee was also the commissioner of DCH until GHA, the Georgia Hospital Association, stole her away. So, okay, it's up to you. Links to care with Georgia hospitals. Go ahead, Kaylee.
Good morning. Thank you, Mr. Chairman, and thank you for the invitation by you and the rest of the committee to join you today. And to Scott, GHA's incoming board chair and CEO of Phoebe, thank you for having us as well. So happy to share a little bit of information, both data and then also some policy issues that we've actually heard already this morning that you'll see kind of as we summarize. But first, a few things that we've been able to pull from the data that we have. Just kind of hospital cancer care. And again, just keep in mind that I'm speaking today from the perspective of our hospital providers, but also recognize, and we'll talk a little bit about really the necessity and the value of our community providers and the partnerships and how our hospitals also rely on those. But as you've heard, Georgia has one NCI designated comprehensive cancer center. 20 hospital-based NCI community oncology research centers, basically folks that are doing clinical trials. A number of other ACS, Commission on Cancer locations across the state. We have a pretty robust set of data related to hospital services and discharge that we've pulled. Over 600,000 chemotherapy treatments, and this is based on calendar year 2023. 28,600 radiation therapy treatments, and then the bottom number is an estimate, could get more specific if you wanted to, Mr. Chairman, but around $147 million in uncompensated care from cancer treatment across the state. We all love a good map, as you heard, so we always start with the State Office of Rural Health's map, and I'll highlight here for you what we've shown. The blue counties are shaded blue are rural hospitals. The peach or salmon are rural counties with a critical access hospital. We have two highlighted in green, and those are our two rural emergency hospitals located across the state in Taylor and Irwin. And then we've tried to go in and label where there are actual services for cancer treatment. Green dots are radiation therapy, either gamma knife or linear reactors, and red dots are chemotherapy infusion locations. We've tried to make some of the dots a little bit larger than others, indicating that there's more than one hospital providing these services in that county. So you can kind of see. However, I will make a distinction. This is really treatment options. It doesn't account for screening services. It's probably fair to say that every county in Georgia is being serviced by a hospital through their community benefit programs in terms of screening access and services. I failed to introduce, but I should not. She needs even less of an introduction than I am. But Anna Adams from GHA is also here with me, and I'm going to invite her to jump in anytime I mess up or forget something. So let's talk a little bit about access to care and how we, number one, preserve the existing access to cancer treatment services around the state, and then also some considerations of how we might improve it. And I think both of those are really important because as we heard that Nita talked about, that some of our service lines around the state really are in jeopardy. But when we talk about access, and Mr. Chairman, you've probably heard me use this for a couple of years now, for us it means a couple of different things, both availability and affordability. It's not just access is one thing, but there are different components. And I've highlighted a couple of these things which you've already heard about today, but I've highlighted a couple that we're going to dive into in just a little bit more detail. Number one is workforce, and that's probably one of the biggest components or barriers to access. Geography and transportation, network adequacy, capacity, internet access in our rural communities, supply chain, reimbursement or payer mix, which we've talked about, and reimbursement rates, affordability, health insurance coverage options, premiums and cost sharings on the member or the patient themselves, financial assistance, the 340B drug discount program we talked, Mr. Moles talked about, infusion services in an outpatient setting, and 340B is so critical to preserving that access. Costs to provide care, and then we heard Dr. Smith even talk about time off work, absenteeism, and presentism as well. So again, I think it's also important to distinguish either ways to preserve or improve access to screening services versus treatment services, and they're a little bit different, and we'll talk about that a little bit as well. In our workforce bucket, again, one of the things that we've been working on specifically for the last couple of years, but has a really big impact on access to both screening and treatment. So we've talked about within the legislature the last few years, licensure for internationally trained physicians and how we can improve our physician workforce programs, the partnerships with our community providers and how important those are to our hospital members. GME support, Nita talked about that specifically in rural areas, but just generally around the state, we have a huge need to continue to improve GME opportunities, and specifically in some of these specialties, but not just the specialties, also primary care and rural medicine, OBGYNs, and all of those things that we know go on the front end and play a really significant role in some of those screening and preventative services. HB 219 was a bill that considered community health workers. It's still viable, as is SB 142, which would have considered licensure for internationally trained physicians. And those have been considered in different committees and are still out there. One of the things we have done over the last couple of years and continue to support is the Georgia Board of Healthcare Workforce. They've invested a lot in new data around licensure data, put up a couple of new reports and dashboards, and the better that they get at that and we can support them in that effort, it really lets us leverage that data to do some analysis on the different needs by communities, geographic regions around the state, on what some of those barriers might be and what workforce needs really look like. We talked about partnerships, and some of those slides where you saw the map where those green and red dots were, some of those services are only available because of the partnerships, not only with community providers, but within or between hospitals themselves. We know over in Effingham and Bullock counties are able to offer services because of their partnership with the folks over at St. Joe's. And so folks are doing that, and the more we can help support them in those efforts, I think the greater you'll continue to see that. We pulled from our data also patient revenue for cancer care. So again, we talk about payer mix, and this really highlights specific to cancer treatments across the state. Medicare accounts for over 51% of those cancer services, payer sources for our patients in Georgia. And this is based off of 2024 data. Commercial payers accounted for 33%, Medicaid at 7%, and then self-pay or uninsured was another 4%. So you can see upwards of 60 or more percent is by those payer sources that are generally reimbursing less than the actual cost of care. I mentioned the 340B drug discount program and supply chain, and this program really makes some cancer services and treatments really more accessible to Georgians that wouldn't have access, at least within a reasonable distance otherwise. There is a pending bill with the legislature, HB 139, related to contract pharmacies, and really all that bill is doing is asking that our manufacturers and our drug companies follow federal law. There have been some conversations more recently, even this week, about the 340B program at the federal level, and it's moving from one regulatory body to another, and so we'll continue to watch that closely. But the more that we can do to preserve access to these programs for our hospitals, the greater our patients will have access to treatment services, especially in rural Georgia. This program is only available at hospitals that serve a high proportion of Medicaid patients, and it continues to be really important. I see Nita shaking her head, so I'm not wrong yet. Good. And then we've heard a little bit about the federal healthcare landscape and shifting priorities. We've all probably heard me or somebody else talk about the federal reconciliation bill and potential Medicaid changes that are in there. Dr. Smith talked a lot about the need to promote programs that incent cancer screenings. One of such program that's in here, we're really grateful that the House preserved that program, our directed payment programs, Mr. Chairman, that we've talked about so much over the last couple of years, but it really limits our ability to expand those programs. One of those includes actual performance metrics. Those payments are at risk and include metrics related to actual improvement year over year by hospitals in their incidence of breast, colon, and cervical cancer screening rates. So they're only getting access to those total dollars if they're making improvements in some of these key metrics that we as a state have identified as really important. So it's really important that we continue to support and preserve those programs both at the federal and state level. And there's other Medicaid changes certainly that we've all heard about pending as well, and we'll continue to do our part to ensure that that Georgians are protected under that. The ACA enhanced subsidies, on the previous slide we talked about coverage options for Georgians. We've got probably latest data 1.5 or 1.6 million Georgians benefiting from federal enhanced premium tax credits. Those are set to expire at the end of this year. If those go away, we've probably got 700,000 to 800,000 Georgians that would fall off of coverage completely, which would then go to, they're still going to show up for treatment and need treatment somewhere, especially related to cancer. It puts more financial pressures on our hospitals and providers around the state that still need to provide and will continue to provide access and coverage to those patients for services, but yet have to figure out a way to make up that bottom line. Medicare Advantage, we've heard a little bit about that. Declining reimbursement, and not just declining reimbursement, but payer practices really. Prior authorization denials, slow payment. I've talked to a number of hospitals whose balances for accounts receivable for commercially and Medicare coverage patients continues to grow and is an increasing issue. So the more that we can highlight and put in some sound practices and requirements around that. Obviously the high cost of drug prices. We've heard a little bit and continue to all read in the news, kind of federal overhauls to our regulatory partners and funding partners at the federal level, the CDC, NIH, and FDA, leads to a lot of uncertainty, right? And it's hard for folks to make plans to continue providing access and coverage really in this changing environment. Public health funding, Megan mentioned a little bit, a number of grants that we administer, the state administers. There's really a lot of uncertainty about how those will continue. And if they go away, what happens and who can step in to help fill that void so that there is no interruption in patient access to care. And then funding for outreach programs at the federal level is continuing to be a topic of conversation that we're watching very closely. A number of grant programs at the federal level are specific for screening services in under-resourced and underrepresented communities. And so we're continuing to watch, and I think those are state conversations we'll need to have, that if those go away, again, who steps in and how do we fill those gaps? Hospitals do a community health needs benefit. You know, we talked about, I think it was Nita said that every community is different, right? And what works in one community may look the same, but it absolutely will not work in another community. So those individual community health needs assessments are really, really critical. What questions do you have, Mr. Chairman?
Questions from the committee? Go ahead.
Kaylee, thank you so much for that very nice information on the state of play. Clinical trials, you mentioned of the NCORE sites. There are 20 sites in the state of Georgia that provide access for patients with cancer. And as you're aware of, clinical trials provide an important source of hope for patients with cancer. It looks like at the federal level, funding for clinical trials may be cut down. And at least that's what we're hearing from the National Institutes of Health and the National Cancer Institute. Are you aware of any other state models where funding mechanisms exist for clinical trials in other states that Georgia could emulate?
I am not. Anna, are you? Not off the top of my head, but we'll take a look. I mean, there are some really good multi-state collaborations and cooperations where folks are sharing best practices and talking about these issues, and so we'll take a look. It was just a couple years ago that Medicaid started paying for clinical trials, and so we certainly want to see that preserved, but to your point, I've heard a number of folks talking about the research capabilities and the risk to public health overall if those go away, so we'll do some extra looking on that.
I would like to say to you, I'd like for us to have further conversations about the Medicare Advantage clawback we're starting to see with providers. You know, I'm hearing that from our individual providers, and I assume that that may be happening with the hospitals also. So I'd like to circle up with you at a later time and have more discussions about that.
We'd appreciate that.
Yeah, look into that. Yeah.
Thank you.
I see no more questions. Thank you very much,
Thank you.
Kaylee. I appreciate it. Okay. Next, Sarah Sessions from the Regional Cancer Coalition.
Good morning, Chairman Hawkins, members of the committee, and guests. For over 2 decades, the regional cancer coalitions have served as Georgia's on-the-ground infrastructure for cancer prevention, screening, early detection, and navigation. While each of our coalitions reflect the unique needs of the communities that they serve, from the mountains of North Georgia to the coastal plains, we are united by a single purpose: to reduce the burden of cancer in Georgia through prevention, early detection, and survivorship. The Regional Cancer Coalitions of Georgia are coordinated, community-based we're the coordinated, community-based evolution of the Georgia Cancer Coalition. We continue its mission, but with deeper roots in local communities, stronger partnerships, and greater flexibility to deliver what works. With funding from the state's share of the tobacco settlement, we have led screening programs, prevention initiatives, patient navigation services, education campaigns, and outreach efforts that meet Georgians where they are. Today, we operate as a coordinated statewide network, fully aligned with the state cancer plan and coordinated through the Georgia Cancer Control Consortium. Our model is not a centralized bureaucracy. It is decentralized effectiveness. That's what allows us to adapt, respond, and reach people that other systems often cannot. We appreciate this committee's attention to cancer care in Georgia, and we're here today as a united voice to share what's working, what we think could work better, and how we could move forward. Now, before I continue, I would like to introduce some of the leaders of the regional cancer coalitions that are in the room today. We have Cynthia from Horizons Community Solutions right here in Albany. Erin Hernandez is in the back there. She is the CEO of the Northwest Georgia Cancer Coalition in the top corner. And then we had Fred Ammons, who is with Community Health Works in Middle Georgia. Our coalitions are not new players. For years, we've built trusted relationships with residents, providers, schools, faith leaders, and civic organizations across the state. Because of this foundation, we are able to reach people that health systems sometimes cannot. Those who are uninsured, geographically isolated, or unaware of cancer risks and resources. We are the boots on the ground, embedded in the communities that we serve. This local trust allows us to reach Georgians in ways that are very personal, flexible, and responsible to the community's needs. Whether it's a church in rural Southwest Georgia, a mobile screening event in the mountains, or a health fair in an underserved Atlanta neighborhood, we are present where the care is often otherwise limited. Our programs are efficient and highly effective. We operate on very lean budgets with high returns. We partner with safety net clinics, public health departments, federally qualified health centers, and hospital systems, not to duplicate their work, but to extend it. We ensure prevention and early detection efforts go beyond clinical walls and into the places where people actually live. Over time, we have proven our ability to adapt, launching new efforts in HPV vaccination, rural mobile outreach, and at-home screening, all shaped by what we've heard from the communities that we serve. And across our patient navigation programs, our screening completion rates consistently match or exceed national standards. What sets the regional cancer coalitions apart is both the depth and breadth of what we do. We don't just respond to cancer. We actively work to prevent it. While hospitals and large systems play a very important role in treatment, we fill the gaps that sometimes they can't reach, bringing prevention, education, and screening directly into neighborhoods, schools, churches, and underserved communities. Let me show you how this works in practice. For years, Georgia's cancer coalitions have led statewide tobacco prevention efforts, reaching over 10,000 students annually through school-based programs, while also working with youth groups, faith communities, and civic organizations. We provide adult cessation programs to connect individuals with the Georgia Tobacco Quit Line to help reduce long-term risk. As smoking rates have declined, youth vaping has surged. In response, we've pivoted our programming to focus on vaping prevention in schools and communities using science-based, age-appropriate education. Interactive prevention models give students real-life insight into the long-term consequences of tobacco and vaping. And you see that in the top corner. That's part of our teen maze prevention decision point. We also work directly with clinic staffs and healthcare providers, offering education and resources on how to talk to their patients about tobacco cessation and the vaping risks, ensuring that the conversations don't just happen in schools, but also happen in exam rooms. Beyond prevention education, we also support schools in enforcement, helping identify retailers who illegally sell vaping products to minors by assisting in vape trafficking and reporting. Our coalitions deliver statewide nutrition and physical education programs designed to reduce obesity-related cancer risks. We offer family education on healthy, budget-friendly meal preparation, senior programs that combine nutrition and exercise over there on the side, and mobile produce markets that bring fresh fruit and vegetables to underserved communities. For cancer survivors specifically, we provide personalized wellness programs that promote physical activity, healthy eating, and long-term health management after treatment. Our sun safety efforts help prevent skin cancer through free sunscreen distribution at community events and public spaces. You'll see this sunscreen in Sanford Stadium there on the corner. Placement of sunscreen dispensers in parks and pools, and the provision of protective gear, such as hats and umbrellas, to outdoor workers and homeless populations. We also deliver targeted UV protection education to vulnerable groups like farm workers and other outdoor laborers who face high exposure risks. In addition, we work to dispel the common misconception that individuals with darker skin are not at risk for skin cancer. Through very cultural tailored education, we help ensure that people of all skin tones understand their risk and take appropriate precautions. We increase HPV vaccination rates through school-based education, family-focused discussion programs, and trusted outreach to address vaccine hesitancy among parents. We help families access low-cost or free vaccines and ensure follow-up through the immunization registry coordination. In addition to youth-focused efforts, we also provide education for adults, emphasizing the benefits of HPV vaccination for individuals who still may be eligible to receive protection later in life, particularly in underserved communities where this awareness is non-existent. Our staff also contributes to statewide HPV prevention work groups, helping shape policies and strategies that increase vaccine uptake and reduce HPV-related cancers that you can see in the middle there. The regional cancer coalitions operate one of Georgia's most extensive safety net screening programs. We provide no-cost or low-cost screenings for breast, cervical, colorectal, lung, and prostate cancers. We coordinate mobile units, at-home test kits, and partner with local providers to reach the patients where they are. Our navigators address financial, logistical, and emotional barriers, helping patients complete screening and access support services during screening. We also offer transportation assistance, financial aid, and connection to local support services. As has already been talked about prior, access to care is not just about having providers nearby. It's also about being able to actually use the care that exists. For many Georgians, particularly in rural and underserved areas, multiple barriers overlap, making it difficult to obtain screening, follow through with care, or even begin treatment. These challenges are often invisible in policy discussions, but represent the daily realities of Georgians. Many patients remain uninsured, underinsured, or struggle with high deductibles and out-of-pocket costs. Even those with insurance often don't fully understand what services are covered or how to navigate their benefits. Our patient navigators and community health workers help patients understand their coverage access financial assistance programs, and avoid delays caused by paperwork and uncertainty. We also directly fund or coordinate thousands of free subsidized cancer screenings across the state. In addition, our teams assist patients in enrolling in available coverage, including Medicaid, Marketplace plans, and other public or private insurance programs, ensuring that Georgians have sustained access to care over time. For those that continue to face financial barriers, we provide gas cards, rides, and food security assistance to support them through their journey. Even when care is available, finding an in-network provider, securing appointments, managing referrals, and coordinating follow-ups can be very overwhelming. Our navigators guide patients step by step, scheduling appointments, managing referrals, and ensuring no one falls through the cracks during their screening or treatment process. Many patients struggle to understand complex medical terminology, risk assessments, or the next steps after they have an abnormal screening. Our staff simplify complex medical information into clear, understandable language. We ensure patients know what's happening at each stage of care, empowering them to make more informed decisions. Stigma surrounding cancer often prevents individuals from seeking care. This is especially true among rural men who avoid discussing symptoms, young women who are facing higher cancer rates, and parents who are hesitant about HPV vaccinations. We use trusted, community-based messaging to overcome that stigma. Our teams engage directly with rural men, young women, and parents to provide credible, culturally sensitive information that encourages screening and vaccination. For many rural residents, simply getting to care is the biggest barrier. We address this head-on by offering transportation support in all different kinds of ways, mobile screening events, and at-home screening tests like a fit test, all designed to get the care closer to where the patient lives. Even after treatment, many cancer survivors face ongoing physical, emotional, and financial challenges that affect their long-term health. We provide survivorship support through wellness programs, fitness and nutrition education, mental health resources, financial counseling, and assistance navigating long-term follow-up care. At every step, we don't just identify barriers, we actively help patients overcome them. We know that this committee and Georgia taxpayers want to be certain that cancer prevention investments are producing real, measurable results. Since 2008, Georgia has received approximately $2.4 billion from the Master Settlement Agreement. Of that, the regional cancer coalitions have received around $21 million during that same period of time. That represents less than 1% of the state's MSA revenue. And yet, with that modest investment, we've delivered one of the strongest returns on investment in Georgia's entire cancer prevention system, leveraging the state's investment for an additional $53 million in federal and private grant funding, which multiplies the state dollars and expands services across Georgia. In the past year alone, across all 5 coalitions, we have directly facilitated, navigated, or paid for 4,000 breast cancer screenings, 12,000 colorectal screenings, that includes both FIT tests and colonoscopies after they are abnormal, 150 lung cancer screenings, 300 prostate cancer screenings, and 8,000 cervical screenings or HPV vaccinations. And we've also assisted thousands with screening, insurance, care navigation, and access to food, housing, transportation, medical care, and other essential services. Finally, we have reached millions through education, public awareness, community outreach, and general prevention efforts. And we've accomplished all of this at the lowest cost per screening facilitated, with the highest reach per dollar in rural and underserved areas, and through deep community-based trust that allows us to overcome stigma, misinformation, and systemic barriers that often other systems cannot. We are efficient. We are flexible. We are embedded. And we are reaching patients that hospitals and larger systems often struggle to reach. Most importantly, we are ready to scale. Georgia does not have to create new structures or systems. The infrastructure already exists all over the state, fully built, fully operational, and fully capable of expanding with any additional resources. We know that budgets are tight, so that's why today, instead of simply asking for more funding, we're offering several practical, low-cost policy solutions that we believe will enhance Georgia's cancer prevention early detection efforts. These recommendations are based on what we've learned in the field and what we've seen work over our regions. These ideas build on infrastructure that already exists, and they target preventable cancers, address known gaps, and make smart use of Georgia's resources without requiring additional appropriations. So first, require nonprofit hospitals to report cancer screening activity as part of their community benefit transparency reporting, and consider establishing a minimum number of indigent screenings to retain that nonprofit standard. Around the state, many nonprofit hospitals, including our host hospital right here in Albany, serve as true community partners and invest significant resources in ensuring that the uninsured and underinsured Georgians receive their timely screenings. Unfortunately, many other large hospital systems do not have that same commitment. This policy would establish a clear, consistent expectation for all nonprofit hospitals, ensuring that every hospital benefiting from tax-exempt status is contributing meaningfully to Georgia's cancer prevention efforts. Second, today, cancer screening coverage in Georgia is governed by federal law and state law. Federal law under the Affordable Care Act requires most health insurances to cover certain cancer screenings at no cost to patients, following guidelines from the U.S. Preventative Services Task Force. At the same time, Georgia law includes multiple additional screening mandates written into different sections of the insurance code. Some state mandates require coverage, other state mandates require no-cost coverage, and in some cases, the timing and guidelines for screenings conflicts between federal and state guidelines. This patchwork creates confusion for patients, providers, and insurers about what is covered, when, and at what cost. If we were to align and simplify these requirements, that would reduce confusion, ensure consistency, and make it easier for both patients and providers to follow evidence-based screening guidelines without the fear of unexpected costs or delays. Third, something very simple. There is no law in Georgia that classifies sunscreen as a medication. However, many school administrators, when they're erring on the side of caution, treat sunscreen like medication and require a permission slip or nurse administration. A simple statutory clarification that explicitly allows students to keep and apply sunscreen would eliminate this confusion and support sun safety from a very young age. Along the same lines, many school playgrounds in Georgia have little to no shade, leaving students with few options to protect themselves from the harmful rays of the sun. Repeated exposure in childhood significantly increases lifetime cancer risks. So including shade planning as a routine part of school design for new construction is a simple, forward-thinking way to build sun safety into the environment at not a very significant cost. For existing schools, low-cost sunshade structures can provide meaningful protection. In fact, a few national mini-grant programs exist for this, and our coalitions have successfully helped several Georgia schools apply for and received funding for that. A small state investment or policy encouragement even could expand this work statewide and make sun safety a permanent part of Georgia's school environment. And then finally, for years, Georgia's cancer coalitions have provided smoking prevention education in schools, and we've seen a real success from that. Unfortunately, vaping has quickly replaced smoking in schools. In response, we've shifted much of our curriculum to focus on vaping and e-cigarettes, working with schools, parents, and youth directly. We also assist schools in enforcing Georgia's sales restrictions by helping them report vape devices with their serial numbers to identify the retailers that sold the vape to the minor that has access to the vape. If we were to tax vaping products at the same rate as tobacco, that would send a clear public health message that vaping is not a safe alternative. More importantly, it would discourage youth use by increasing cost barriers that reduce access and experimentation, especially among kids who are price sensitive. We believe these can help Georgians reach more people, detect more cancers early, and ultimately save lives and dollars. We'll close with 3 key takeaways. 1, Georgia has a unified statewide cancer control infrastructure, the Regional Cancer Coalitions of Georgia. We are embedded in communities, coordinated statewide, and delivering prevention, screening, and navigation across all of Georgia. 2, we are efficient, adaptable, and community-rooted. We reach those who are uninsured, those who are in rural areas, and those hesitant to screen, delivering services hospitals and systems often have trouble doing, and we do it cost-effectively. And finally, we are ready to scale. Georgia doesn't need to reinvent cancer control. It simply needs to strengthen what already exists and scale what is working. We thank you for your time, your leadership, your commitment to improving cancer care access in Georgia. We would welcome any questions, and we would welcome working alongside this committee for the months ahead.
You certainly give us some things to think about and study at a later time, for sure. Taxation of vaping and sunscreen among those. Are there any questions from the committee? Okay, I see none. Thank you very much. Appreciate it. Very good report. Okay, up next is the ASGE colorectal screening project. We have Crystal Owens and Dr. Carla Belcher.
All right. Good afternoon, or I guess it's still morning, so good morning. I'm Carla Belcher, and I'm the CEO for Community Healthcare Systems, and we're delighted today to be asked to tell you a little bit about a project that we're doing with the American Society for Gastrointestinal Endoscopy. That's the only time I'm going to say that because I just stumble all over it, so it's ASGE. But anyway, thank you for this opportunity. The first thing I want to do is just tell you a little bit about, do you want me to wait for you to get my slides? I'm sorry. Trying to be respectful of everyone's time. Okay.
Thank you, Justin.
All right, so we'll go to the next slide. Is that right? Oh, wrong one, this one. Okay, just to tell you a little bit about ASGE, they actually advance patient care and digestive health by promoting excellence and innovation in gastrointestinal endoscopy. The organization's focused on training, research, and education, has set more than 17,000 members worldwide. And if you want more information about specifically what they do, you can go to asge.org for additional information. Let's see, we'll go to the next slide. What I really want to do is tell you a little bit about Community Healthcare Systems. We're actually a federally qualified health center, and we're in all of those counties listed up there. But I do want to point out that we're located in many counties with no rural hospital. If you remember the slide that Nita provided to you, there's quite a few counties in the east central part of the state that do not have rural hospitals, and that's where our FQHCs, a lot of them are located, are in those small communities. We provide the best and most comprehensive services available regardless of a patient's insurance status or ability to pay. That's the cornerstone or capstone for what federally qualified health centers do. We see everyone, regardless of ability to pay, and anyone at 200% of the federal poverty level or below can actually receive our services on a sliding scale. We offer additional programs to our patients in terms of screening, but we also provide primary care. And in our organization, we provide family medicine, internal medicine, podiatry, dental services. We have behavioral health services, and we provide linkages to care too for specialty care. Also wanted to mention here before I move on from this slide is some of the things that Dr. Smith pointed out in his American Cancer Society presentation. And he talked about screening, and I think he talked a little bit about colorectal cancer screening as well, but he talked about screening in general, and that it's not organized, and that the rates of screening are predominantly flat. And I just want to make a plug here for community health centers and how much we focus on prevention and how much we really look to try to increase awareness of the types of screenings that patients need. And we provide access to those, and we also provide access to it for the patients who are uninsured. And because we're in rural areas, we are able to provide those services in these rural locations. Community health centers in the state of Georgia are in 130 counties in our state, and so some of the information that we talked about the whole day around barriers to care because of location, we're trying to meet those needs where we are. I think there's still a big problem in terms of transportation, which Nita really talked about. When people need to go to the next level to get care, to be able to have, if they need chemotherapy or surgery or something like that, and that needs to be done in a larger tertiary area, that is a struggle for patients. We provide transportation assistance through gas cards and those kind of things, but I do think that's somewhere where people really struggle. Even if we can get them in to actually receive the screening, and then they need to have follow-up care, we struggle trying to get them to that next level, and I think that's something that we can all do a better job of and try to come up with some innovative solutions. Just to tell you a little bit more about colorectal cancer and screening, colorectal cancer is the leading cause of cancer death in men under the age of 50, and it's the second leading cause of cancer death in women who are under 50. More than 5,000 Georgians are estimated to be diagnosed with colorectal cancer, and nearly 1,700 are expected to die of colorectal cancer in 2025. And I will say here too, one of the reasons that we were I guess encouraged, or we really wanted to participate in this pilot project in cancer screening or colorectal cancer screening, is we had done a lot of things individually on our own trying to improve our rates, because we do track the rates of colorectal cancer screening and other prevention screenings that we do in our health center, but we haven't been able to move the needle quite like we felt like we should in this particular area. And so that's one of the things that really prompted us to be involved in this program, and Dr. Owens is going to tell you a little bit more about some of our successes and how far we have to go with that. The follow-up colonoscopy rate for underserved patients who have a positive stool-based test result is estimated to be just 50 to 70%. I would probably tell you that in our estimation that might even be lower in some of our areas, because people do struggle to get to that next step with the colonoscopy. And I do want to put a plug in here for the regional cancer coalitions in our state that we do work with a couple of them. We work with Horizons, and we also work with Community Health Works, and we really appreciate that partnership, that we're able to bring our patients to an effort where they can actually receive their colorectal cancer or their colonoscopies. The net healthcare cost in the first year after a CRC diagnosis ranges from $36,000 for stage 1 to $74,000 for stage 4 disease. This is truly significant, and I think I participated in a summit last year where it said that I believe if you can once a patient has been diagnosed with colorectal cancer, that they've got a 4 to 6 month opportunity window to where they can actually receive the treatment options before their outcomes significantly change. And so I think it's really important to focus on, once someone has been diagnosed that they do need further care, that we get them into care and we get them into it quickly. And I think that's where some of the navigation efforts that we've been trying to talk about here today really can improve our outcomes, save our state money, and also improve quality of life for the people that live in Georgia. And then lastly, colorectal cancer has a 90% survival rate when it's detected early enough. And so that just, really kind of reemphasizes the fact that we need to do more around trying to get people to engage in colorectal cancer screening. for this project, what we were trying to do is we're increasing colorectal cancer screening rates and follow-up rates for the underserved, and reduce the amount of time from the abnormal test to follow-up colonoscopy. And that's what we have been doing so we started this project back in July, and we really made great strides. We found a champion within our organization, and she has really worked hard to coordinate and collaborate with our partners in terms of navigation. And we've seen some increases in our screening rates, and also just getting information back for our patients. We actually had, just in the last year, we've had a 7% increase in our colorectal cancer screening, which is pretty significant in less than a year. We wanted to gain a better understanding of the barriers for timely follow-up. We wanted to educate, which is one of the things we're doing today, to be an advocate for sustainable sources of funding. And the goal was to screen 600 underserved patients for colorectal cancer, including 300 in Georgia and 300 in Maryland. I will tout I will say kudos to our organization. We're more than two-thirds there. We're close to two-thirds into that. So yay, Georgia. I think we've done a good job. And then we want to complete a web-based playbook to increase colorectal cancer screening and follow-up rates. And the projected funding with a grant from Exactive Sciences and support from Iowa Pharmaceuticals and Braintree has really helped provide the resources for that. With that, I'm going to turn it over to Dr. Owens, and she's going to tell you a little bit more of the nitty-gritty, and she can answer the questions that doctors can answer instead of people like me or administrators. Thank you.
Good morning. My name's Dr. Crystal Owens. I have actually worked at a federally qualified health center in rural Georgia for 20 years, and I went to Mercer Medical School and trained here at Phoebe, so it's nice to be here. Again, telling you a little bit more about our ASG colorectal screening project. We want to, again, increase colorectal screening and follow-up rates for the underserved. Oh, I'm sorry. We're actually going to the next slide. Okay. All right. So ASGE and CHCS, our goal is to help 300 underserved patients in Middle Georgia get screened for colorectal cancer. And we're using stool-based tests at no cost to patients. So I will say in our health center, we're able to do FIT testing, so patients can bring in a FIT test, which is good for an annual screening. We can provide, again, the Cologuard test, and we partner with Exact Science. So when the patient comes in, we'll educate them on the Cologuard. The test itself will be shipped to the patient's house. So again, they can complete that test at home and send it back. Generally, they're going to get their test results probably within 2 weeks or so. I do like the fact that Exact Science actually sends out reminder texts to patients. I can tell you that I personally completed this test myself, my husband and I. So if you put it there in the restroom, you're probably likely to complete the test. Colonoscopies, again, is the gold standard, and we still are definitely advocating for patients to get colonoscopies. But I think we know that there is a shortage of endoscopists and a shortage of healthcare providers throughout the state, and we want our population to be screened. The number of Cologuard tests that we've ordered to date are 173. The number of completed tests are 81. Cologuard positive abnormal rate to date was 18.52%, which actually I thought was a little high. So again, this may be reflective of that high-risk population. And again, we're seeing increasing rates of colorectal cancer in younger and younger patients. Follow-up colonoscopies, again, have been scheduled and completed to date. That was 11. And again, we a shout out to our Albany-based Horizons Community Solutions, providing patient navigation services. So as a primary healthcare provider, I can tell you that we do need help on the front lines. I mean, getting patients from primary care to that specialist care navigation is wonderful for filling in those gaps, making sure they know how to complete their prep, making sure they get to their appointments and they're appropriately prep for the procedure, and again, those barriers that we talked about with transportation and other financial issues. We are actually currently working with medical students also, Mercer Medical College of Georgia. We're taking our EMR, or electronic health records, pulling out information of those missed opportunities and trying to figure out those barriers to patients being screened. Okay, so I think we have a video next. So this is This is Tennille, Georgia. Okay, well, we can just look and proceed. Okay, we apologize. Again, ASG colorectal screening project, our next steps. So again, we want to complete those 300 screenings for underserved patients in Middle Georgia by 2025. We want to advocate to expand the colorectal screening project through appropriations via Georgia Department of Public Health for underserved patients in Georgia in 2026. Again, we're analyzing the colorectal screening data projects in Georgia. I know Ms. Belcher spoke about, having a champion there within the health center, and again, we're tracking that patient data and, making sure we're learning from the data and trying to, promote more screening among our patients. Create and market a web-based playbook to increase colorectal screening and follow-up rates in Georgia and across the U.S. for 2025 and 2026. Okay, so our key takeaways are it's crucial for people who are 45 years of age and older to get screened for colorectal cancer. Again, the screening rates or the screening recommendations used to be for up to age 50, but now that's been scaled back to 45, and we're seeing increasing rates of colorectal cancer screening among younger and younger patients, and we've talked about those things that can contribute to those things. Georgia should strive to increase its colorectal screening from 67% to 80%. I do think in certain parts of the state it's actually lower than 67% in certain pockets. So, rural areas, I think, again, I've worked there a long time, and providers, we are on the front line, so we can remind our patients and stress the importance of these screenings. Georgia should expand its efforts to screen underserved patients for colorectal cancer. And as we have mentioned, if you detect screening early or if they're diagnosed at an early time, there's a 90% survival rate. So an investment in programs like these is an investment in prevention. So colorectal cancer screening, it does save lives. I've actually participated on the roundtable for about 5 years, Access Work Group. We've done lots of different activities around the state to raise awareness. But again, I think health centers can be a key player in this because we are in these rural areas. We are primary health care providers. We see these patients on a daily basis, and I feel like we can help promote screening. So thank you for the opportunity to speak to you. If you have any questions for us.
Yeah, I've got a question for you. We've seen a move toward the Cologuard kits. I see that on the television advertised all the time. How reliable are those kits in your estimation?
I think when I looked it up, it was like a 96% sensitivity rate. I think it has a higher sensitivity than FIT tests, but of course, colonoscopy is the gold standard. But actually, I think it's a reliable test. Okay. And again, if you get a positive result, you're actually sending the patient to the next step, which is a colonoscopy. Right. But you can kind of meet patients where they are.
Right. Okay. Any other questions?
Yeah, and I could respond to that too. With Cologuard, there's a Cologuard 2 coming out that's more sensitive and more specific. My problem clinically with Cologuard has been there's a lot of false positives. And so what that means for the patient is they're waiting a month or two for a colonoscopy, like, oh goodness, I've got a positive test. So technology is only improving. So yeah, look out for Cologuard 2.0.
Yeah, there is a Cologuard Plus.
I would like to say too that I think some patients, and one of the things that we try to do with the medical students is try to find out why, even when we can offer them a free colonoscopy, they still refuse to do that. But at least if we can get them to do that screening to start with, that's I guess like she said, meeting them where they are, but trying to find out what the hesitancy is around trying to either have any kind of screening, because some patients will not do any of it.
And there are a lot of insured patients that for some reason won't get screened. So we, really are trying to do a deep dive into what those barriers are. So.
Well, thank you very much. I appreciate it. That wraps up today. I would like to thank our committee for all your travels and all your work. The media services from the Capitol, thank you for your work. Thank you, presenters, today. You brought us some very valuable information. And thank you, guests, for being here with us and supporting this effort. Our next meeting will be in July, I believe, 8th and 9th. in Augusta, MCG. So I'll look forward to seeing you at that time. Thank you very much.